The following podcast is part of a certified educational activity titled Stories Behind the Science in EGPA. Updated strategies for diagnosis, treatment, and reducing the steroid burden in patients. Access the entire activity and complete the post-test at peerview.com/AHR860. Downloadable slides and practice aids are also available.
Welcome, everyone, and welcome everyone who's on Zoom. Today's panelists, which are myself, Anna Kowalski, and Dr. Michael Wexler, will give you a rundown of how we diagnose, how we treat, and potential new targets in this disorder. Our goals for today: improve your ability to reduce diagnostic delays by promptly recognizing symptoms that may suggest EGPA, augment your knowledge of the pathophysiology of EGPA and the rationale for targeted biologics, enhance your understanding of the evidence for new and emerging therapies, and equip you with strategies to personalize treatment and use steroid-sparing therapies for patients who present to you with EGPA. This is my section. I'm going to be going over the diagnosis, how we make the diagnosis. So I'm an associate professor of medicine at University of Michigan, and I'm also the fellowship program director. And I have some of my learners here, which makes me very happy. Thank you for coming. And I will talk to you about, would you recognize EGPA if you actually saw it? So what is EGPA? Eosinophilic granulomatosis with polyangiitis is a classically considered among the small vessel disorders of the ANCA-associated group of vasculitides. It's relatively rare, 5,000 cases per year in the United States, approximately 14 cases per million. Mean age at onset is around 40 years, but it varies, and it occurs equally in both men and women. Of course, it can be underestimated. Why would it be underestimated? It's rare. It can present as asthma and severe asthma. And of course, we treat severe asthma with systemic corticosteroids, so we can mask the potential evolution of this over time. And drugs that are partially able to control the symptoms, even high-dose inhaled steroids, can potentially mask us realizing that the person actually has EGPA. Characterization of EGPA. So moderate to severe asthma in over 90% of patients. Peripheral eosinophilia, so greater than 10% or at least 1,000, in some studies 1,500. Mononeuropathy or polyneuropathy, pulmonary infiltrates, paranasal sinus disease or polypoid disease, extravascular eosinophils and eosinophilic vasculitis on biopsies. And there is a positive ANCA, which is perinuclear, myeloperoxidase specific, in 30 to 40% of all patients. As you can see, with all of those symptoms associated with this disorder, there has to be a multidisciplinary approach in EGPA. And I will say, in treating these patients over time, what I've noticed is that pulmonologists, rheumatologists, and allergists are the drivers of the therapies, but a lot of other specialists are part of the care, of the evaluation, potentially of the monitoring of the symptoms, such as the ones listed here. The main clinical characteristics of EGPA on the basis of ANCA status. So ANCA negative and ANCA positive EGPA can present slightly differently. However, there is significant overlap between the two. So eosinophilia, nasal polyposis, and chronic rhinosinusitis, asthma are part of both. However, some of the other features, such as more lung-predominant disease, cardiomyopathy, gastroenteritis, are more common in the ANCA negative, and in the ANCA positive, glomerulonephritis, peripheral neuropathy, and purpura. This is a slide demonstrating that eosinophilia is an extremely important overall cascade that has to make us think about many different mechanisms. And when we see patients who have EGPA, some of the subcategories they already have, such as asthma and potentially nasal polyps. But in addition, we have to rule out many items, such as drug reactions, ABPA, malignancy, parasitic infections. And so there's a very large differential diagnosis when we see these patients. How about the clinical course? So it's usually evolves. It's somewhat phasic. There's a developmental pattern to it. However, the stages can overlap, and you may see a patient straight in the eosinophilic phase without knowing much about the prodromal phase. So you have to be aware of these patients that present at any level. So typically, the prodrome is an allergic diathesis, and this is the vast majority of allergy patients. So they will have allergic rhinitis, which can be a little bit more significant, more sinus disease potentially, and then they progress into an asthma, and often this is adult onset, and they may precede systemic disease by many years. Then there's an eosinophilic phase. This is where the peripheral blood eosinophilia occurs, and there's eosinophilic infiltration into various organs. And finally, the vasculitic stage, which is necrotizing vasculitis and granuloma formation. And the hope is that they don't get to that phase, that we potentially block that phase by treating them. And it doesn't have to develop over years. It can develop potentially over months. So what about the differential diagnosis of EGPA? So this is a very nice slide that we put together. In 2007, I read the whole article.
It's true.
Yeah, it does. And it has all the history of how things evolve over time, which is really nice. But chronic eosinophilic pneumonia has mainly peripheral imaging findings versus EGPA and hypereosinophilic syndrome, which tend to be more patchy. The big picture idea of what I want you to see here is that EGPA involves many different organs and many different aspects. Chronic eosinophilic pneumonia is a little bit more organ predominant, like lung predominant, and hypereosinophilic syndrome doesn't have the vasculitic ANCA type degree that EGPA does. So they present somewhat differently. But they're all part of the differential when we see these patients. So the recommended diagnosis for EGPA, and there's not a diagnosis that's fully accepted, absolute. It's often very clinical, and you take tidbits of those aspects that I mentioned earlier of what we see in these patients. So under the blood test, they should have significant hypereosinophilia. Always check the ANCA serology. Inflammatory markers are not specific, of course, but if they're present, they just are a sign of inflammation. Total IgE can be elevated. Flow cytometry is important to rule out lymphocytic variant hypereosinophilic syndrome. They often tend to be low titer rheumatoid factor positive and potentially ANA and others as well. And then, of course, checking the urinalysis and also the creatinine for kidney involvement is really important. Pulmonary-wise, it's important to get a baseline CT of the chest and pulmonary function testing and potentially BAL if you would like to verify the eosinophilia, though it doesn't always have to be present. And it's not as severe as in chronic eosinophilic pneumonia. GI-wise, for ischemic disease, endoscopic evaluation, or for eosinophilic colitis, potentially. Cardiac-wise, an echocardiogram and an EKG are important, and EKG alone is not enough. Need to have an echocardiogram. And then, of course, markers of myocardial damage, troponin, and then also for heart failure, BMP. And cardiac MRI and PET can be useful and a little bit more sensitive, but they're not always available or done. And for patient-specific concerns, such as neuropathies, EMGs, and biopsies. So this is a diagnostic criterion that's used in the phase 3 trials, and Michael is going to talk about this in the MIRROR trial. I like this. I actually asked PeerView to put this in because when I think about these patients, this is kind of the way I come to the conclusion, not just from a vasculitis angle, which I'll talk about in a minute. So these patients tend to have asthma and eosinophilia, and two of these criteria had to be met for these trials. So a biopsy showing the actual evidence of the vasculitis or of the eosinophil infiltration or of granulomatous inflammation or all of the above. Neuropathy, mono or polyneuropathy, pulmonary infiltrates, which tend to vary and are non-fixed, abnormalities in the sinuses, and also potentially cardiomyopathy, which is not as common, glomerulonephritis, and alveolar hemorrhage, which is pretty rare, and then palpable purpura, as well as positive test for ANCA. And MPO or PR3 are listed. The PR3 is usually more consistent with GPA, though there are some patients with EGPA that have PR3 antibodies. So in terms of the workup, I just wanted to put the invasive tests here so you can see like how you could potentially figure out if somebody has EGPA based on the biopsy. And there are many ways to evaluate the tissues. Probably the least invasive is a skin biopsy, but all the way up to kidney biopsy and potentially even endomyocardial biopsy. And I have had patients with all of those types of biopsies as well. And need to look at and rule out hypereosinophilic syndromes. That's one of the main differentials, and I'll get into that a little bit more with the patient case that we're going to present. But that's for bone marrow biopsy and T-cell immunophenotyping. So this is an actual classification criterion. It's the latest one, and it's put together by the American and the European Rheumatology Associations. And it is coming from the other angle, as I mentioned. So when somebody already has a biopsy-proven small or medium vessel vasculitis, then what will make that person classify into an EGPA diagnosis? And if there's 6 or more of these classification criteria points positive, then the likelihood, so the sensitivity and the specificity is actually very high for this. So of course, everything I mentioned earlier, so obstructive airway disease, nasal polyps, and mononeuritis multiplex give points. And then also the highest points are for blood eosinophil counts, which are elevated. Those are not so specific to EGPA, but really elevated ones could be. And then also the findings on the biopsy. The negative points are things that make us think more of granulomatosis with polyangiitis, previously known as Wegener syndrome. So PR3 and C instead of P-ANCA antibodies. What about the burden of disease? So despite its rarity, the range of organ systems involved, the relapsing remitting nature of this disorder, creates significant patient burdens, healthcare system burdens, including substantial levels of oral corticosteroid over time with high risk of the complications associated, asthma exacerbations, healthcare utilization, and quality of life impacts. This is a patient survey after the Mandara study, which Dr. Wessler is also going to go through today, of all the different items that they felt. So there were greater than 35 different symptoms reported as bothersome. And out of these, there were many that we've discussed. So the nasal components, the lung components, impaired ability to work and to exercise and to sleep and to engage in social activities, and also some difficulty with everyday activities. This is a patient that is HIPAA compliantly discussed today, a patient that I follow. So he presented for ongoing asthma flares and management, along with history of eosinophilia, and no active management outside of everything that we think about. So nasal steroids, antihistamines, montelukast, and also combination long-acting beta agonist and inhaled corticosteroids. He had a history of rhinitis and asthma in adulthood, so it was adult onset. The rhinitis started longer ago than the asthma, and he developed severe diarrhea and abdominal pain. Evaluation revealed an eosinophil count close to 11,000, but he had been between 11 and 23,000 off and on for some time. And colonoscopy showed either eosinophilic colitis or ulcerative colitis. Further workup was initiated. He had a bone marrow biopsy that did not have evidence of a neoplasm, and he had myeloid hypereosinophilic syndrome targeted evaluation, which was also negative. He did have transiently a perinuclear ANCA, anti-MPO positive, but which did turn negative over time. His CT scan had the migrating ground glass opacities, especially on the left. PFT did have obstruction, and then the CT scan of his sinuses did have abnormalities as well. He was eventually tapered back to his typical items that I mentioned earlier, but because he had more hyposmia and chronic sinusitis symptomatology, clarithromycin was added. And his eosinophil count was quite elevated over time, but he was on no active therapy otherwise. He was given a diagnosis of EGPA/chronic eosinophilic pneumonia.
It's so great to be here, and thank you all for joining us at this hour. I'm going to talk a little bit about targeted treatment and some of the underlying pathophysiologic mechanisms in EGPA. After that great clinical introduction about how to make a diagnosis and how to identify patients with EGPA. As we know, the E of EGPA is the eosinophil, and eosinophils play a major role in the pathophysiology of EGPA, and they can cause significant tissue damage, which is a major manifestation in EGPA through release of a variety of different cationic proteins, granular proteins, as we'll discuss. And they can also be associated with the development of tissue fibrosis in these patients once there's resolution of some of the inflammation. In terms of what causes EGPA, it's not fully known, but we know that there is a combination of factors that play an important role. In general, we believe that people have to have, like most other diseases, a genetic predisposition, some type of environmental factors and insults, and then some type of immune dysregulation that can result in the key manifestations of this disease. We generally think that EGPA's main two characteristics are that there's an eosinophilic inflammatory component, and then there's the vasculitic component, and they may or may not be related in all individuals. In terms of the eosinophilic component, we generally feel that there is some type of insult that is upstream and oftentimes at the epithelial layer that can result in the release of epithelial alarmins, such as TSLP, IL-25, and IL-33, which can then stimulate Th2 cells and ILC2 cells, innate lymphoid cells, to produce different cytokines, including interleukin-5, which is the key cytokine that's involved in the activation, maturation, and proliferation of eosinophils. And then those same cytokines can result in the activation and release of different granular proteins, including major basic protein, eosinophilic cationic protein, eosinophil-derived neurotoxin, eosinophil peroxidase, that can result in some of the eosinophilic inflammatory processes. In addition to the eosinophilic component, there's also a vasculitic component. And this is a much more complex process, which isn't quite fully understood. But the feeling is that these anti-neutrophil cytoplasmic antibodies are recruited to sites of tissue damage in the blood vessel wall that can result in recruitment of other inflammatory cells to those sites in specific organs. We don't know quite what causes these antibodies to be recruited, or why they might go to some tissues as opposed to others. You heard all the variegated organs that are involved. We don't know why some people only get involvement in the heart, and some people in the kidney, and some people in the skin, and some people in the nerve, or combinations of all of those. But once these eosinophils get into the tissue, that's where they release all these different granular proteins like MBP, eosinophil peroxidase, eosinophil cation protein, eosinophil-derived neurotoxin, that can cause a variety of the pathophysiologic features that we see in EGPA, including airway remodeling that we might see in asthma, some endothelial dysfunction that we see when patients develop thrombosis. There can be neurotoxicity, myocardial fibrosis, and also recruitment of other inflammatory cells through Th2-dependent mechanisms. All of these different features are key to the pathophysiology of EGPA. Now, we know that one of the central drivers of the eosinophilic component is interleukin-5. And interleukin-5 plays such an important role, along with other cytokines as well, in terms of the differentiation of eosinophils, the migration of eosinophils from the bone marrow into the blood, and then from the blood into the tissue, where they can be activated and cause release of these different granular proteins. Now, it isn't just IL-5, but IL-5 is the dominant cytokine that causes all of these issues. Interleukin-3, GM-CSF also play roles in terms of the activation, proliferation, maturation of eosinophils, and the trafficking of eosinophils from the different compartments to the other different compartments is mediated primarily by IL-5, but also by other cytokines, including interleukin-4 and interleukin-13. The key advances that we've had in the last 8 years or so in the management of EGPA has been the utilization of therapies that target interleukin-5 or the interleukin-5 receptor. And we now have these two therapies, mepolizumab and benralizumab, that have been approved for the management of EGPA, particularly for patients with relapsing or refractory EGPA. Mepolizumab is a monoclonal antibody that binds IL-5, and by binding IL-5, it prevents IL-5 from binding to the IL-5 receptor, and therefore prevents the activation, proliferation, and maturation of eosinophils. Benralizumab, as you know, is an IL-5 receptor antibody. It binds to the IL-5 receptor and does two major things. One is it prevents IL-5 from binding to the receptor that it's occupying. And second of all, the benralizumab bound to the IL-5 receptor is recognized by the immune system as a foreign body and can result in antibody-dependent cell-mediated cytotoxicity, with killing off of the cells that the benralizumab is bound to, resulting in depletion of those cells. So with benralizumab, you have two different mechanisms of achieving lack of eosinophil activation, but also their depletion through the activity of natural killer cells. So now we're going to move on to our next section, and we're going to talk a little bit about personalizing treatment for patients with EGPA. The science behind the story. So what are the goals of EGPA treatment? So it's important to stand back and say, when we have these patients, what are we trying to accomplish? And we've got a few different major goals. One is to try to treat the inflammation. The second is to try to prevent relapses. And the third is to reduce the toxicity of induction therapies. And we have a variety of different induction therapies that are often utilized, as we'll share with you. In 2021, there were recommendations by the American College of Rheumatology and the Vasculitis Foundation for the management and treatment of EGPA. Those guidelines suggested a few different types of patients need to be treated differently. Patients who had acute severe EGPA versus those who have acute non-severe EGPA. For patients who have acute active severe EGPA, it's recommended by those guidelines to initiate therapy with pulse or high-dose IV glucocorticoids and cyclophosphamide or rituximab. Those are based on the recommendations of the management of other vasculitides and of other ANCA-associated vasculitides, such as GPA, granulomatosis, polyangiitis, and MPA, microscopic polyangiitis. And then, for patients who achieve remission on cyclophosphamide, the recommendation, like for those other vasculitides, is to switch cyclophosphamide to methotrexate, azathioprine, or mycophenolate. For severe disease relapses after remission with cyclophosphamide or rituximab, the recommendation is to utilize high doses of glucocorticoids with rituximab following the initial induction treatment. For active non-severe EGPA, on the right-hand side, the recommendations are a variety of different options. One are glucocorticoids with anti-IL-5 therapy with mepolizumab or benralizumab, glucocorticoids with methotrexate, with azathioprine or mycophenolate, or with rituximab. And one could consider glucocorticoids alone in select patients, particularly those patients who have a low 5-factor score, meaning they have no involvement of the kidneys, the GI tract, the central nervous system, or the heart. For non-severe disease relapses on methotrexate or azathioprine alone or mycophenolate or on glucocorticoids alone, the recommendations were, for active non-severe disease, to add glucocorticoids and anti-IL-5 therapy with mepolizumab or benralizumab. And for patients who are on anti-IL-5 or rituximab, to consider a different immunomodulatory approach based on the clinical history. In 2022, the European League Against Rheumatism, the EULAR group, they advocated for a slightly different approach that included evaluation to induce remission and to maintain remission. Now, inducing remission is getting patients when you first see them fresh, and you want to get them out of their active disease state. They also divided patients who, for induction of remission, into life-threatening, organ-threatening disease, or not organ-threatening or life-threatening disease. For patients with organ-threatening or life-threatening disease who have active EGPA, they also advocated for utilization of cyclophosphamide or rituximab in combination with glucocorticoids. But for non-life-threatening and non-organ-threatening disease, the recommendation for patients who had relapsing or refractory disease was to start anti-IL-5 therapy. Again, the options being now benralizumab and mepolizumab. The goal then is to taper glucocorticoids. And once you start glucocorticoids, the goal is to get down to the lowest dose possible. The patient is able to achieve remission, which we've defined for EGPA as having a Birmingham vasculitis score of 0 and being on 4 milligrams or less of glucocorticoids. Then the patient can, continue being followed by an expert consultant. However, if a patient isn't able to achieve remission, then you need to go back to the drawing board and you need to consider alternative therapies, whether it's switching to azathioprine, methotrexate, or an anti-IL-5 therapy or rituximab. If the patient achieves sustained remission, then you taper the glucocorticoids. Patient doesn't get sustained remission, you need to consider alternate therapies. always considering the patient's risk for side effects, relapses, comorbidities, and the patient preference.
The adverse effect of corticosteroids are not something that we don't all know about, but I'll just briefly mention it. Unfortunately, corticosteroids, as you saw, are often the mainstay of at least initial therapy in EGPA. They have tremendous drawbacks and are cumulative issues. So obviously, they can cause neuropsych effects, glaucoma and cataracts over time, weight gain and diabetes, growth suppression if it's a young person, immunosuppression and infections. Adrenal insufficiency is extremely common, osteoporosis and fractures, and also skin thinning and bruising. And so our goal is always to get these patients off of corticosteroids as much as we can, but they may still require them during flares. So how do we monitor these patients? There's not one or two items that are amazing for monitoring. So how we monitor them is usually clinically. So some laboratory findings, we can still look at inflammatory markers, make sure that they are not developing kidney disease, especially in those who are ANCA positive. Monitor the drug toxicities, as I mentioned on the previous slide, the actual eosinophil counts. But again, patients can have symptoms without necessarily eosinophil count changes. Imaging can be monitored over time and initially also, and then pulmonary function testing, and emphasize to the patient to let you know when they're not feeling well. There is one marker which is not on here that I spent some time thinking about. IgG4 was mentioned as a possible better marker for monitoring, which I haven't done, but I might start doing. I don't know if you've done that, but
yeah, I mean, IgG4 is present in a subset of patients who have granulomatous disease oftentimes, and can be involved in terms of there can be IgG4 in a variety of tissues. So if they have elevated IgG4, it can be utilized as a biomarker. It doesn't necessarily correlate with disease activity. Similarly, ANCA levels can be followed. And there was one study in 2003 by Ulrich Specks and colleagues from the Mayo Clinic, which demonstrated some correlation between ANCA titers and disease activity. That has not been replicated in subsequent studies. So one of the hallmarks of these guidelines is that they really are following on the vasculitis literature, where there is almost reflex utilization of disease-modifying agents against different rheumatologic diseases, including azathioprine, mycophenolate, and methotrexate. But what's interesting is that those recommendations are not based on double-blind, placebo-controlled trials. And a good example is this study of azathioprine. Even though azathioprine has been utilized as add-on therapy to glucocorticoids, there's been one study by Puekal and colleagues that was published in 2017 that evaluated the addition of azathioprine versus placebo on top of glucocorticoids. And in this trial, randomized controlled trial of azathioprine versus placebo, there was no significant difference, as you can see on the left, in terms of the proportion of patients remaining relapse-free or the mean prednisone dose that patients were able to achieve. So there wasn't any significant steroid-sparing effect. It didn't diminish EGPA or asthma or rhinosinusitis exacerbation risk in this patient population of non-severe EGPA. So we have to take with a grain of salt a lot of the recommendations and guidelines that are not based on randomized controlled trials. Because once we do placebo-controlled trials, we might find out that therapies that are being utilized may not necessarily have the efficacy that we think. Now, one of the key advances in the management of EGPA has really been the introduction of anti-IL-5 therapies or therapies targeting the IL-5 receptor. This study that we published in the New England Journal of Medicine in 2017 was called the MIRA trial. And in this study, we randomized patients in a double-blind, placebo-controlled manner to receive, on top of glucocorticoids, patients who had relapsing or refractory EGPA to receive mepolizumab, the anti-IL-5 therapy, 300 milligrams once a month, versus placebo. Of note, the 300 milligram dosing of mepolizumab is different from the asthma dosing of 100 milligrams a month. So that's the one important thing to note. The key findings of this study was that mepolizumab resulted in a greater proportion of patients achieving remission over the course of the 52 weeks of the study, with remission again being defined as achieving a glucocorticoid dose of 4 milligrams or less and a Birmingham Vasculitis Activity Score of 0. In addition, what was demonstrated was that there was a significant reduction in the number of relapses with mepolizumab compared to placebo, and an increased time to relapse with mepolizumab versus placebo. This, I think, was the first major study, double-blind, placebo-controlled study in any of these vasculitis, but particularly EGPA, and resulted in the FDA's approval later that year. One of the other key findings was the reduction in glucocorticoid dose. Patients who were treated with placebo started off at around 11 milligrams a day of prednisone and ended up, after the 52 weeks, at around 11 milligrams a day of prednisone. But patients treated with mepolizumab had a reduction in their dose from about 12 milligrams a day to about 5 milligrams a day. They cut their oral steroid dosing by about 50% in that patient population. And over 57% of patients treated with mepolizumab achieved a greater than 50% reduction in their daily oral corticosteroid dosing. In fact, almost 20% of patients in this trial treated with mepolizumab were able to come off of steroids completely versus only 3% in the placebo arm. So mepolizumab became the standard of care from 2017 onwards for the management of relapsing or refractory EGPA. And this led to the Mandara trial. The Mandara study, which was published this past year in 2024 in the New England Journal of Medicine, was a double-blind, randomized controlled study comparing benralizumab 30 milligrams on a monthly basis, which is different from the asthma dosing, which is 30 milligrams monthly for 3 months, followed by every other month, compared to mepolizumab, 300 milligrams a month, which was the approved dose in EGPA. Patients received this therapy for a year, with the primary outcome again being the proportion of patients who were able to achieve remission at weeks 36 and 48. Following this 52-week study, patients were then allowed to go into an open-label extension study where they received benralizumab 30 milligrams every month. One of the key primary outcomes was the time to first relapse in this phase 3 study. And by the way, this is one of the few, if not only, studies comparing head-to-head two biologics in asthma or related diseases in a double-blind manner. What was demonstrated here is that there was no significant difference between benralizumab and mepolizumab. Benralizumab was non-inferior to mepolizumab in terms of time to first relapse, the proportion of patients who were able to achieve remission. In fact, 59% of benralizumab patients and 56% of patients treated with mepolizumab were able to achieve remission at weeks 36 and 48. This was actually even a higher percentage than what was demonstrated in the MIRA study. As you can see, the two curves almost completely overlap. One of the key findings, and again, Anna mentioned how problematic corticosteroids are for these patients, for any patients who are on chronic steroids. We looked at the proportion of patients who were able to achieve a 50% reduction in steroid dose, 100% reduction in steroid dose, and just getting on to 4 milligrams or less. What was demonstrated was that almost 85% of patients treated with benralizumab and 74% of patients treated with mepolizumab were able to achieve a 50% reduction in steroid dosing and getting off of steroids completely, which is so important to our patients. 41% of benralizumab patients compared to 26% of mepolizumab patients were able to come off of steroids completely. In the MIRA study, in the placebo group, only 3% of patients were able to come off of oral steroids. So here we're seeing 41% of benralizumab patients and 26% of mepolizumab patients. That's huge for this patient population. And in terms of getting down to a dose of 4 milligrams or less, almost 70% of patients, 7 out of 10 patients, and patients had to start off with a steroid dose of at least 7.5 milligrams in this study to get into the study. So 70% of patients were able to get down to 4 milligrams or less. In terms of safety, both benralizumab and mepolizumab are very safe and well tolerated. As you can see, there's no significant difference in terms of the proportion of patients who had any adverse event or who had serious adverse events. The incidence of serious adverse events was extremely low in both patient populations. This trial did occur during COVID. As you can see, about 20 to 27% of patients did develop COVID in the clinical trial. Otherwise, these therapies are well tolerated with similar rates of adverse events. Headaches, arthralgia, nasopharyngitis, and sinusitis were observed with slightly greater frequency. Just as an aside, well, first of all, I'll just mention there are other emerging therapies, and I'm excited about the fact that while we now have 2 different options for the management of EGPA, there are currently several trials ongoing evaluating other therapies. Depemokimab is a ultra-long-acting anti-IL-5 therapy that was studied and published last month in New England Journal of Medicine in patients with eosinophilic asthma. It's administered every 6 months. So imagine twice yearly therapy. So we're studying that in the OCEAN trial with a drug called depemokimab. Tezepelumab, as you know, is a anti-TSLP therapy. It targets thymic stromal lymphopoietin. It's approved in asthma of all sorts, and it acts upstream of IL-5 and IL-13 and IL-4 and can be effective in asthma. It's being studied in EGPA. SHR-1703 is another IL-5 targeted therapy. And then JAK inhibitors, which work downstream of the IL-5s and other cytokines, all work through JAK-dependent mechanisms, is also being studied for patients with EGPA. What I was going to say is that, incidentally, while the prior guidelines that have been published don't necessarily advocate for anti-IL-5 therapy in patients with acute EGPA, that's because it just hasn't been studied in that patient population. In both the MIRA study and the Mandara study, patients needed to have relapsing or refractory EGPA and a history of EGPA for 6 months. It doesn't mean that those therapies may not necessarily work in the acute setting. They just haven't been studied in that setting. But you should know that all of the other current recommendations, whether it's glucocorticoids or cyclophosphamide or azathioprine or methotrexate, have not been studied in that patient population either. So, what have we reviewed today? We've talked about the fact that EGPA may be unrecognized due to its rarity, and that high eosinophil counts on lab workup should be noted and identified as potential risk factors and should signal that a patient could have EGPA or other related eosinophilic diseases like hypereosinophilic syndrome, like chronic eosinophilic pneumonia, or just eosinophilic asthma. It's important to recognize that EGPA requires a multidisciplinary approach in terms of diagnosis and treatment. EGPA can present to you as allergists based on the history of asthma and sinus disease, can present to pulmonologists based on the asthma or pulmonary infiltrates, can present to ENT doctors, can present to cardiologists, rheumatologists based on the vasculitis, or it can present to renal specialists, emergency room specialists, and the like. While corticosteroids are first-line therapy, they are associated with significant side effects and toxicity, and we've developed a significant understanding of the underlying pathophysiology of EGPA, and that's led us to utilize other therapies that have been major advances in the management of EGPA, including the utilization of IL-5 targeted therapies or IL-5 receptor alpha targeted therapies, such as mepolizumab and benralizumab, which have really changed the landscape for the management of EGPA. And now we are working on developing other therapies, and so we'll have more tools to better treat these patients with EGPA. All right, now we're going to talk a little bit about the story behind the science. Anna, do you want to review and return back to John?
Do. Okay, so John had a viral URI and he developed an asthma flare. He was treated with prednisone 60 milligrams for 5 days, and a bunch of labs were ordered when a consultant to me saw him. And his eosinophil count after that was 5,600 after the steroids, which I deemed an incomplete response to oral steroids for hypereosinophilia. And the reason that's important is that subsequently I ended up doing a lot more evaluation, because the one thing so hypereosinophilic syndromes can also be treated with anti-IL-5s, but myeloid variant hypereosinophilic syndrome tends to be steroid refractory, and that's what I wanted to make sure he didn't have. So upon reevaluation, while going off of the oral steroids, he did develop a splinter hemorrhage over his right index finger, and also fatigue and sinus congestion. He was admitted to the hospital after I heard about this, and I wanted to make sure he didn't have heart involvement, so we worked him up for that. I also wanted a rheumatologist to evaluate him, because if he does have significant nerve or heart involvement, I wanted him to potentially be treated first with either IV steroids or Rituxan or cyclophosphamide. And none of that occurred. He was relatively clinically stable. So he was actually started on a long high-dose steroid taper. 60 milligrams was the initial dose, and also anti-IL-5 therapy monthly. Further evaluations included the myeloid NGS panel to Nationwide Children's, which targets way more items than the FISH panel he had prior. His SED rate was elevated. He was ANCA negative still. He did have normal immunoglobulins, although they were elevated, and these patients can have this gamma globulonemias. IgE was not very high in him. He did have an elevated rheumatoid factor and also ANA, which also happens in some of these patients. B12 was initially elevated and normalized. That's what concerned me about myeloid variant. His LDH was normal. His tryptase was normal. Those are all features of myeloid variant HES. Creatinine and UA were normal, looking for kidney abnormalities, which would prompt more significant Rituxan or cyclophosphamide. His workup was otherwise okay for parasites, and his flow and T-cell gene rearrangements were normal. This is looking for lymphocytic variant hypereosinophilic syndrome. And then all of his imaging. So at this point, his sinus CT did not look good. However, his chest CT looked better after some steroids and initiation of anti-IL-5. Looked more consistent with asthma rather than the migrating infiltrates. And then his abdominal CT, the big point here is that the rheumatologist wanted to make sure they didn't see anything that looked like a vascular issue, and also that he didn't have splenomegaly, which can happen in myeloid variant hypereosinophilic syndrome. And I did have him do an EMG that was mildly abnormal as well. So this is the final point about him. So you can see his FEV1 and also his FVC were quite impacted, and he was also obstructed. And both of those parameters, while he still remains somewhat obstructed, significantly improved on his spirometry following these therapies. He is now, I believe, on 2 milligrams of prednisone. He has not had a flare, and he's been on his targeted anti-IL-5 therapy. And my plan is to get him fully off if I can, but we'll see. So ask us questions, and we will try to answer them the best we can.
We already have several questions up here already. I do want to highlight one key piece of the diagnosis and management. Feel free to sort of type in your questions or raise your hand, and we'll have someone come to you if you don't want to speak up with regard to questions. But in terms of the workup management, it's critical to take a good history, do a good physical. The major things you want to exclude are you want to make sure that there aren't other causes of eosinophilia, that you're not missing a drug reaction that could be causing eosinophilia, that you're not missing some type of parasite. And then, in addition to drug reactions and parasitic infections, you want to make sure that you're not missing a malignancy of some sort as well, because there are patients with lymphoma, leukemia that can present with hypereosinophilia. Let's go through a few of these questions. Is there someone here who wants to speak up? Yeah.
How do I tell if a patient that has eosinophilic asthma, rhinosinusitis, maybe a little bit of hypertensive cardiovascular disease, has EGPA or not?
Yeah, so you have to, cardiovascular disease is very common. And you said asthma, sinus disease, you said a little bit of eosinophilia. So I think it's the eosinophil count that's usually the tip-off. We're talking about eosinophil counts in usually more than 1,000. And if they don't have an eosinophil count more than 1,000, then it's unlikely. Could they just have eosinophilic asthma and not have EGPA? Again, what I'm looking for is something beyond just eosinophilic asthma. Do they have organ involvement? So when I think of a continuum of asthma, eosinophilic asthma, with or without sinus disease, which is common. You throw in some pulmonary infiltrates on top of that, that's eosinophilic pneumonia. What we're talking about in EGPA is having something beyond eosinophilic asthma with or without pulmonary infiltrates with other organ involvement. And you need to either have identification of that other organ involvement by history, by physical, or by other imaging, as Anna outlined already. Do they have, if it's cardiac, do they have elevations of troponin? Do they have a cardiomyopathy or myocarditis as identified on echocardiogram or on cardiac MRI? So it can be. You need some other organ system involvement. That's correct. Any other questions in the audience? I see a hand up over there. We'll take a question here. What's the possibility of developing anti-IL-5 neutralizing antibodies? So those have been identified in about 10% of patients, but they aren't thought necessary to have any pathological clinical implications. Good question. Oops. Yeah.
Thank you for taking my question. Where do you see benralizumab being used after seeing the open label extension data and data on switching from mepolizumab?
You want to handle that?
Would I switch someone from mepolizumab to benralizumab if I didn't have appropriate response? I think that's the question. Yes, I probably would.
Yeah, I think our goals are to achieve remission in all of our patients. And so if a patient is achieving a remission on mepolizumab, I would continue mepolizumab. If the patient isn't, unless there's some other compelling reason, like a cost issue or something along those lines, personal preference. there are a couple of advantages. While both mepolizumab and benralizumab are non-inferior to one another, there are a couple of potential advantages of benralizumab compared to mepolizumab. One, it's only 1 shot a month versus 3 shots a month. So that's one thing. And so over the course of a year, we're talking about, 12 times 3 or 13 times 3 is 39 shots versus 13 shots. So that's one issue. The second issue is the greater depletion of eosinophils that occurs with benralizumab compared to mepolizumab. And the third thing is related to that is what we demonstrated was there was a greater proportion of patients treated with benralizumab in the Mandara study who were able to get off of oral corticosteroids completely, 41% versus 26%. That being said, if patients in remission, I'm happy.
Thank you for taking my question. As we know, these patients are typically treated for severe asthma and have undergone some biological treatment before reaching the diagnosis of EGPA. My question is, do you have any experience regarding the involvement of dupilumab in this development of the EGPA?
So dupilumab blocks IL-4 and 13 by blocking the IL-4 receptor alpha. Because IL-4 and IL-13 are involved in trafficking of eosinophils, by blocking IL-4 and 13, you might result in reduced trafficking of eosinophils from the blood into the tissue. So where will they stay? They'll stay in the blood. We did an analysis of all of the dupilumab clinical trials that we published a couple of years ago in the Journal of Allergy and Clinical Immunology. There were, I think, 4,000 patients studied. There were 6 cases of EGPA in those clinical trials. Of note, patients were excluded in the asthma trials with dupilumab if they had eosinophil counts of more than 1,500. I actually think that several of those patients, in reviewing those cases in detail, probably had evidence of EGPA previously, and they may have had incipient or form fruste of EGPA. I have no specific concerns of giving dupilumab to that patient population because we think that, again, the eosinophils may not get into the tissue. But if they've got very high eosinophils, makes me a little bit nervous. So over 1,500, I use caution.
I wanted to mention that there are some case reports of using dual biologics, especially in hypereosinophilic syndrome. And I have seen personally patients do reasonably well if uncontrolled on an anti-IL-5 alone with the addition of IL-4 and 13. And I feel more comfortable with them not getting the severe hypereosinophilia if they're concomitantly on anti-IL-5.
When we achieve the clinical remission, eosinophil is nearly zero and no symptom status. Have you ever tried to extend the interval of anti-IL-5 antibody?
Yeah.
And how long? How we extend? And finally, we may stop the benralizumab as well.
Yeah, great question. The question is really for patients who've achieved remission on a biologic, and this could be applied to asthma or EGPA or any other disease, what do you do? Do patients have to stay on these therapies lifelong? Well, there have been no good studies evaluating this. In an off-label manner, I have a shared decision-making discussion with my patients. And many patients say, well, why would I want to stop? I'm doing so well. And other patients say, well, I've been doing so well for over a year. So if patients are doing well for over a year and they want to stop drug, I don't advocate for stopping cold turkey. What I recommend in an off-label manner is to increase the interval of dosing. Some patients can stay off of therapy once they get to a certain point. Other patients cannot, and they require long-term therapy because they may have rebound hypereosinophilia. Again, that's a good question that needs to be studied. We'll do 2 quick rapid-fire questions. As you achieve remission, start steroid. Once you achieve critical dose, will you re-increase dose of corticosteroids or switch treatments? Yeah, I'll do both. Usually if someone relapses, I will increase the steroid dose to get them under control and switch treatments. What's the likelihood that a pediatric patient with elevated eosinophilia will progress to EGPA with end organ damage and vasculitis? While it's rare to have pediatric EGPA, it does occur. It's infrequent. We published a few case series in that regard. And there's actually someone at my institution, one of the fellows that I worked with, Jessica Bloom, who's now on faculty at University of Colorado, who's studying pediatric vasculitis, including pediatric EGPA. And the last question, is there any biomarker for the diagnosis of vasculitis in patients having eosinophilic infiltration in target tissues? Well, just the biomarkers that we've discussed, including the eosinophils. There's no better biomarker like IL-5 or any other biomarker or eosinophilic cation protein. They don't tell you anything that eosinophils don't. And share your experience how to taper anti-IL-5 therapy. We've already discussed that. So thank you so much. Have a great day.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca LP. To access all materials for this activity, visit peerview.com/AHR860.